assistant, old assistant.
Dr. Srinivas Pai is MBBS, MS, all from Manipal. Sir.
You told you I was talking to him, sir. I've seen him, sir, when I came there.
Good evening, sir.
Good evening. Good evening.
Sir, I think it is 8 o'clock. We will start now. Good evening, friends. Thank you for joining for yet another edition of PG Clinics. I welcome all the senior faculty, Rajgopal sir, Jayalal, Guru Shantappa sir, Ajay Khanna sir will be.
Hello.
HOD from Dharwad. And we have Shabi Ahmed Thomas from joining from MLN Medical College, Prayagraj. I'm sure Dr.
Dr. Kanakwelo, your voice is interrupted.
Contributed by Professor Guru Shantappa sir. Thank you very much, sir. And in fact, she happens to be the undergraduate student of Srinivas Pai sir. World is so small. And we have another candidate kindly contributed by Professor Rajavelu sir from Vellore Medical College, Dr. Parthiban. He will be presenting a case of metastatic breast cancer. So, friends, and I think we are on time. Let us have the first presentation. Dr. Archana, can you please start sharing your presentation? And I'm sure all the faculty are seniors here and they've been with us for many programs. But to remind them, let the candidate be allowed to present without stopping till the clinical history part. Then everybody can question or correct her. After that, again, when they are presenting the clinical finding, allow her to present till the end. Both the candidates have collected the investigations also. So I would recommend, request all the faculty to touch upon the investigations and management also. The time allotted for each case is about 1 hour. Thank you very much. And I wish you all the best, Dr. Archana. Go ahead. Good luck to you. Introduce your unit chief, your head of the department, and start your presentation.
Good evening, everyone. I'll be presenting a case presentation on the topic neck swelling under the guidance of Dr. Guru Shantappa Yelagachin sir, Professor and Head Department of Surgery, KIMS Hubli, and myself, Dr. Rachna S, postgraduate student in the Department of Surgery, KIMS Hubli. Here is a 53 years old female homemaker by occupation hailing from Hubli, presented with chief complaints of swelling in front of the neck since 2 years. Patient was apparently all right 2 years back when her family members noticed a swelling in front of the neck, following which the patient became aware of the swelling. The swelling was insidious in onset, initially small in size, gradually progressed over 2 years to attain the current size. It is not associated with pain. There is no history of sudden increase in size of the swelling. Patient also gives history of frequently waking up at night, but it was not associated with stridor, dyspnea, or orthopnea. There's also history of weight loss despite good appetite. She also gives history of recent hair loss. There's no history of palpitations, excessive swelling, or heat intolerance. There's no history of recent change in voice. There's no history of difficulty in breathing or difficulty in swallowing. There's no history of diplopia. Coming to past history, she is a known case of type 2 diabetes mellitus since 15 years and is on tablet glimepiride and metformin twice daily. She's also a known case of hyperthyroidism since 2 years and is on tablet carbimazole 10 mg BD and tablet propranolol 40 mg BD. She is not a known case of hypertension, asthma, tuberculosis, or epilepsy. There's no history of exposure to radiation to neck in the past. She underwent tubectomy 25 years ago and hysterectomy 8 years ago. There's no history of similar complaints in her family members. Coming to obstetric history, her obstetric score is para 3 living 3. She underwent tubectomy 25 years ago. She attained menarche at the age of 14 years and she underwent hysterectomy 8 years ago. Coming to her personal history, she consumes vegetarian diet with a good appetite. She has a disturbed sleep. Her bowel and bladder habits are regular. There's no history of substance abuse. Coming to the summary, a 53 years old female patient, known case of hyperthyroidism since 2 years on antithyroid medications, presented with complaints of painless progressive swelling in front of the neck since 2 years with history of loss of weight despite good appetite and disturbed sleep and hair loss. She's also a known case of diabetes mellitus on oral hypoglycemic agents. I would like to give a diagnosis of benign thyroid swelling in hyperthyroid state.
Faculty, please take over.
Rachna,
Yes, sir.
this is Dr. Sahai.
Yes, sir. Good evening, sir.
Just go back to your first slide. Yeah, just two small comments. Since you said since 2 years,
Yes, sir.
right? I would be happier if you said for 2 years rather than since, because since when you have a specific time,
Okay, sir.
right? And just go back to your first slide, please.
Yes, sir.
And also your comorbidities like diabetes, because she's still having diabetes, can't be past history. So you just discuss all this in as a separate list as comorbidity.
Okay, sir.
Front of neck since 2 years. Okay, right. Next slide, please. So why does she wake up at night? Any reason you've stressed about her?
She says due to anxiety, she wakes up frequently at night, sir.
Okay. So she's having anxiety together with hyperthyroidism.
Yes, sir.
Okay, we'll discuss this later when you do examination. Okay. Right. Next slide, please.
I have a question.
Yes, sir.
Yes, please.
The symptoms of hyperthyroid that you described
Yes, sir.
came after the swelling, or there was along with the swelling?
She noticed it it was present along with the swelling, sir.
Okay, I thought it happened later on. The swelling appeared and then she had features of hyperthyroidism.
But when she had the hyperthyroidism symptoms,
Yes, sir.
then she noticed the swelling along with that.
Yes, sir.
Or there was a period where there was only swelling, no symptoms, and then she got all these symptoms.
No, sir. It was told by her family members, sir. Upon that, she noticed the swelling. And when she consulted a doctor, she already had symptoms of thyrotoxicosis, hyperthyroidism.
Hyperthyroidism.
So how does it become then past history, Rachna? Will you show your past history slide?
Yes.
Yeah. So how does your hyperthyroidism come under past history?
So the symptoms at present have been resolved, sir, of hyperthyroidism.
No. So that does not mean that it should come under past history. So what probably, remember, it's an ongoing process of 2 years.
Yes, sir.
If you were to say that patient had some swelling 2 years duration, and maybe 5 years back, 10 years back, something like whatever you have written there, na? All
Yes.
the diabetes. This is your history starts with the 2 years itself now.
Yes, sir.
What you should have told patient 2 years, whatever that for these complaints, patient consulted so and so, diagnosed to have hyperthyroidism. Then she was put on such a drugs and all that thing. That should become the continuing process. It doesn't become past history.
Rachna, you have said that 2 years is on antithyroid drugs.
Yes, sir.
But I couldn't understand. You are saying there is no sudden increase in size. With the 2 years of antithyroid drug, what you are expecting on the thyroid on the side? Second, what symptoms has reduced? That all comes under the present history. You should be bringing on this treatment what symptom has reduced. Now, again, you are putting other symptoms, loss of weight, loss of appetite, and increased appetite. Something is a bizarre thing is there. And 8 years back, patient had hysterectomy. And how did he have the symptoms of hyperthyroidism? What was the findings the 2 years back?
Sir, 2 years back, she had palpitations, tremors, sir, which have subsided now, sir, with the use of antithyroid drugs, sir. She does not. currently complain of palpitations.
Do you think 2 years of anti-thyroid drug is necessary to say that is a treatment is there?
Sorry, sir.
For hyperthyroidism, is it
Yes.
necessary to put 2 years of treatment and still the patient is having symptoms of hyperthyroidism? Is that the treatment is responding to that?
No,
Patient.
partly she has responded, sir, because her palpitations and sweating and tremors have reduced, sir.
No, he is on continuously propranolol is there. 40 milligram propranolol for 2 years.
No, sir. The propranolol has been started 2 months ago, sir. Initially, she was only on tablet carbimazole, sir. The dose has been tapered over a course of 2 years, sir.
So
But
in
your
fact,
presentation gives a,
yeah, in fact, the whole idea of telling you all these things is
Yes, sir.
do it properly, because that's where the confusion happens to all of us. So you should have presented it like, here is a patient who has got a swelling of whatever the 2 years duration, and patient, it was associated 2 months later, whatever palpitation. For these complaints, she went to so and so, so and so. She was started on some drugs. If patient tells you carbimazole, say carbimazole. Don't have to, you are a postgraduate, not undergraduate. How do you know carbimazole? All sorts of things. How many times per day? 3 times, 4 times? Doesn't matter.
Yes.
After that, you should have immediately told that after that, there are some temporary symptoms have improved. That means we know. Now the question that comes is why she is losing weight. You understand, no?
Yes, sir.
Symptoms of the palpitation has come down.
Yes,
So
sir.
for that, you have to probably give an explanation why patient has lost weight. Is it of any other consequence or any other things? So how the response to the treatment, which patient is, responded to well to the treatment, whether she wakes up from the night because of the palpitation, all that has to come in this type of case, right?
Yes.
Okay.
what has happened to the size of the team?
Sir, 1
Goitre?
second, sir. Sir, we have Professor Shabi Ahmed and Dr. Arkat Rekha joining up, sir. Sorry for the interference, sir. There was some communication gap in the Zoom connect. Now they have joined us, sir. Faculty, kindly take over, sir.
Any change in the size for the last 2 years on the continuously on anti-thyroid drug? Do you expect the size of the tumor to be reduced? Because activity has to come down. That means your size of the tumor has to come down. Goitre has to come down.
Yes,
But
sir.
you are not asked the question. You are only asking there is a sudden increase in size. What was the goiter size 2 months? Because you said it is a primary. Palpitation, anxiety, so looks like a primary thyroid toxicosis he had.
Yes, she does not. She's not able to. It was since the swelling was noticed by the family members. So she's not aware of the swelling size coming down or not. So
No,
also,
see, here comes a patient where you are able to say carbimazole 10 milligram, propranolol 40 milligram. There is a very well history you are able to elicit from the patient.
yes, sir.
That means if you are asking from the patient, you could have elicited the history much more. This now it is 2 years becoming a hidden period. Or you are not able to give us a good clue. And you started with presenting the patient is apparently normal before 2 years, and suddenly coming and saying 8 years back she had a hysterectomy. So don't use that word what was normal 2 years back or not normal 2 years back. It's a known diabetic for 15 years. So what you present, the patient has noticed the swelling of the 2 years back. Now on the patient is on anti-thyroid drug. So what is response, as Dr. Sanai sir has said, whether partially responded or what responded, you should have put. And now present what is the present feature of the case. And still you have to explain how she is getting up in the midnight. What is the reason she is getting up?
She
That
becomes.
means there is a sleep disturbance is there.
Yes, sir. She says she becomes anxious, sir, but it is not due to palpitations, stridor, or dyspnea. She wakes up at night, sir. It's just mainly because she gets anxious
No,
at night.
don't drag on to see what is palpitation, what is anxiety. Then that is a big question. Now you know for sure patient is anxious, getting up. That means it is he still has a problem of sympathetic overactivity.
Yes,
That is why he is getting up.
See, that's what I was trying to tell you, that her symptoms, she is losing weight and anxiety is there, and insomnia is one of the very, very strong features of the primary thyrotoxicosis actually. You know, earlier there used to be a scoring system. Nowadays we don't use it. That's why I don't want to tell you that. Insomnia is one of the very, very important part of the
Hey,
primary thyrotoxicosis. Yes, please go ahead.
Now, why do you think she is losing weight despite your medications? Is there a logical answer? Which is that
Yeah.
medication which is causing her to lose weight in that?
Sorry, sir.
Metformin. Because of metformin,
Metformin, yes.
another thing is your chronology of history, went little this side, that side. That's why the confusion.
Okay, sir.
Like, to summarize what everybody said. Okay.
Yes.
Why did we ask you which came? Why did I ask you which came first, the goiter or the symptoms? What's the
Sir,
reason for me to ask that?
So because in primary thyrotoxicosis, the swelling and the hyperthyroid features are presented at the same time, sir. Whereas in secondary thyrotoxicosis, swelling precedes the symptoms, sir.
Thank you. Is it possible that she had a swelling and never noticed it? Okay.
Quite,
And then she had hyperthyroidism. And then because of the weight loss, she noticed the goiter. Is it possible like that?
it is quite possible, sir, since the swelling was noticed by her family members. So it might be a pre-existing swelling which went unnoticed.
Why did you say benign? I mean, you use the word benign, no?
Because the swelling is gradually progressive, sir, and also there is no history of sudden increase in the size of the swellings.
What are the causes of sudden increase in size in case of thyroid?
It could be a hemorrhage, sir, into the swelling.
Which is
Or,
the most common?
Sorry, sir?
Which is the most common? Which is the most common cause of sudden increase in size of
Hemorrhage,
swelling?
sir. Hemorrhage into
Hemorrhage.
the swelling. Or if we are thinking in terms of a malignancy, it could have infiltrated the surrounding neural structures that could have caused the malignancy can cause sudden increase in swelling.
what malignancy? What
Since there's a-
malignancy will have a sudden increase? No?
So since it's a pre-existing swelling, sir, or like follicular carcinoma, sir, which is the most commonly seen in
Follicular
goiter
or something?
or an anaplastic carcinoma, sir.
So previous nodule of thyroid or the follicular carcinoma is the commonest.
Yes, sir. In a previous thyroid nodule, follicular carcinoma is the most common malignancy, sir.
What is the commonest tumor you get out of Hashimoto's thyroiditis?
Papillary,
In Hashimoto's.
papillary cancer.
Yeah.
What else other than papillary? Or which surgery is not done, but still patient does well.
Sorry, sir.
Which are the malignancy for which surgery is not done, but still patient can be cured in Hashimoto's?
What is the other tumor other than papillary carcinoma? What other carcinoma what other tumor can come in Hashimoto's?
Other than
Further,
not
further-
carcinoma, but some other malignancy.
lymphomas.
Yes.
Squamous cell carcinoma can come, but it's extremely rare. Okay.
Okay.
These are the three.
Lymphoma.
Lymphoma is and papillary are equal, almost equal to each other.
So whether this patient is now hyperthyroid at present according to you or not, your clinical presentation?
Yes, clinically, the patient is still hyperthyroid, sir, because she has there's still weight loss despite of good appetite. Also, she has a disturbed sleep, and there's also hair loss.
I think move on to clinical examination.
Yeah.
Coming to general physical examination, a 53 years old female patient, moderately built and nourished, conscious and oriented to time, place, and person. Her Karnofsky performance status is 90. Pulse rate is 102 beats per minute, measured in right radial artery, regular in rate, rhythm, and volume. Her blood pressure is 110 by 70 millimeters of mercury. She's maintaining saturation at room air, and she's afebrile. There's no pallor or pedal edema. She has eye sign.
Please note in the eyes, general examination, you have repeatedly said, don't use Karnofsky score when you are going to talk about a benign thyroid swelling. Second, you are so far in the history, you are talking about anxious, getting up from the bed. But what is the status of the patient at that time? Whether she is anxious looking, whether she is a comfortable normal, that is what we need to say now. And what are the other features, general examination in the hyperthyroid patient?
Moist hands, sir.
No, all those things is not there. The general examination, don't, it is specific to your case. You are going to do the general examination.
Yes, sir. She was quite comfortable, sir, at the time of examination. And the other things I would look for is since she's hyperthyroid, she might we would like to examine the pulse and tremors, sir, if she has any tremors in the general physical examination. Also, she has eye signs, sir.
Okay, go ahead.
She has lid retraction and this Telvac sign noted. Coming to local examination of the neck, on inspection, a swelling of size approximately 6 × 4 centimeters is noted in front of the neck, extending vertically from thyroid cartilage up to 2 centimeters above the suprasternal notch and horizontally up to anterior border of sternocleidomastoid on either sides, smooth surface. The swelling moves with deglutition, lower border is made out, skin over the swelling appears normal, trachea appears central. On palpation, a swelling of size 6 × 4 centimeters.
Madam, I want to interrupt you.
Yes, sir.
On inspection, you are telling that trachea appears central. Just justify.
Sir, if trachea would have...
On inspection, how it
yes,
is?
on inspection, if there is a tracheal shift, sir, there would be prominence of the sternocleidomastoid over the... where there's on the ipsilateral side, sir, trail sign would have been seen, sir. So I would like to say that trachea appears central.
And how will you check the tremors?
Sorry, sir.
How will you check the tremors of the hand?
Tremors. The patient is, yes, sir. On outstretched hand, the patient is asked to is examined for fine tremors for about a period of 30 seconds, sir, with outstretched hands.
Is it a physiological tremor or a pathological tremor?
In pronation or in supination?
In pronation, sir.
Why not in supination? Which muscles are weaker?
Hand
Flexors or
muscles.
extensors? Flexors or
Extensor.
extensors?
Extensors.
Proceed.
Krishna, can you define a fine tremor? Can you define what is fine tremor, what is cold tremor? Can you say what is tremor?
A tremor is a muscle twitch noted, sir. Twitching of muscles.
So much things, muscles. There are so many muscle twitches there.
Fasciculation, sir.
There is a lot of difference between fasciculation, tremor, fibrillation. No, you know what is fine tremor. What is normal physiological tremor? Every one of us, when you go for a surgery or something, sometimes you get a tremor, or examination, you get a tremor. Is it the same tremor you get in hyperthyroidism or a different tremor?
So
it is only a physiological, exaggerated of the physiological tremor. With a high frequency, low amplitude tremor is called fine tremor. You must know what is the positional tremor, what is rest tremor. There's a lot of things on tremor. You must, as a postgraduate, you must study that detail.
Yes.
Hello.
Just a suggestion, Rachna, for you.
Yes, sir.
About the trachea. If in inspection, if I find the trachea is central, right, just leave it at that.
Yes, sir.
It doesn't make a difference because you will come in palpation anyway.
Yes.
On inspection, if you find a deviation, then tell the finding why it is deviated. Better that way.
Okay.
Instead of telling a normal one and getting into problem, might tell it in palpation if it's normal position. You understood know what I'm getting
Yes,
at?
yes, sir.
Second thing is a fine tremor is one where you have to examine the patient to diagnose it. Whereas a coarse tremor patient himself will complain that my hand is going here and there. Okay. Coarse tremors are diagnosed on history, whereas fine tremors are diagnosed on physical examination. Physical examination.
Yes.
Okay, go on.
Yes.
How did, have you told how did you test for tremors?
So the patient is asked to outstretch the arms, hands, or on with pronation, and we look for the tremors for half a minute.
There is another thing to look for fine tremors, because sometimes you
Tongue tremors,
you get tongue without protruding it.
protruding,
See that
without protruding it.
the other time you place a paper on the tips of the fingers, and the tremors get amplified, and it is much easier to detect these fine tremors.
Yes.
Sometimes you can't see this fine tremor. But seeing your inspection, one thing I want to say that the swelling is clearly extending below the sternocleidomastoid, more on the right side than on the left side. And you say that is reaching only up to the anterior border, which I find there is a protuberance below the sternocleidomastoid, more on the right side. So I think that, okay, let's see what palpation says.
Coming to palpation, a swelling of size 6 to 4 centimeters is palpable in front of the neck, extending vertically from thyroid cartilage up to 2 centimeters above the suprasternal notch and horizontally extending up to the anterior border of sternocleidomastoid muscle on either sides with nodular surface, moving with deglutition. The lower border of the swelling is well made out, firm in consistency. Trachea is central in position. Bilateral carotid artery pulsations are felt at its normal position. There are no palpable lymph node in the neck.
How did you look for the position of the trachea? How did you test for the position of the trachea?
Place index finger and the ring finger over the sternoclavicular.
There is a thyroid swelling about 6 centimeters in front of the trachea. How did you look for the central?
In the over the suprasternal notch, sir, because that is free. The swelling is above the 2 centimeters above the suprasternal notch. So with the ring forefinger and the ring finger at the over the sternoclavicular joints, and use the middle finger to trace the trachea position of the trachea.
Here you have a swelling, and especially the patient is slightly obese. So could you feel that the trachea below the swelling?
Yes, I could feel.
Sometimes it is difficult, especially in obese neck, and especially this thyroid swelling is going down right up to the suprasternal notch. In that condition, how will you see whether the trachea is deviated or not? Actually, it is difficult clinically when it's in such a situation. Then you have to rely on certain investigations.
Radiographs.
You do a radiograph and then look whether the trachea is deviated or not. Yeah, go ahead.
How will you palpate thyroid gland? There are different methods for palpation of thyroid gland.
Yes, sir. One is Lahey's method, sir. That is done. Palpation is done by standing in front of the patient, sir, and the left to palpate the.
Lahey's method is for the palpation of the single lobe.
Yes, sir.
One lobe.
Yes.
For
both the lobe, we stand behind the patient, sir, with neck slightly flexed, sir, with thumbs behind at the nape of the neck, and the the other 4 fingers over the swelling, sir. We palpate the thyroid glands.
What is role of thumb and what is role of 4 fingers? We have to keep thumb over the occiput.
Yes.
For the flexion and extension of the neck. Yes. And with the concavity of the 4 fingers, thyroid gland is better palpable.
Yes.
These are the 2 methods, and one more is a Cray's method, that is for the individual nodules. Okay, proceed.
On percussion, there's resonant note heard over the sternum. On auscultation, no bruit is heard over the swelling. Coming to systemic exam. Sorry, sir.
Rachna?
Yes, sir.
What is the importance of this test, resonance over the sternum?
Sir, if there is a retrosternal extension of the swelling, sir, there will be a dull note heard on percussing the sternum. Sir.
What is the difference between a plunging goiter and a retrosternal goiter?
Retrosternal
How
goiter.
do they-
Retrosternal
Go ahead.
goiter. Retrosternal goiter is the lower border of the swelling as is going beyond, is extending retrosternally, sir.
But clinically, how will you differentiate between these two?
If you know answer, Rachna, say.
Sorry, sir.
Otherwise, can you feel the lower bound? So ask you clinically, how do you know whether it's a retrosternal goiter, isn't it?
Yes.
So if you can feel the lower border, then it's not. If you can't, then of course. What about auscultation? That helps you to locate the trachea, doesn't it? If you can auscultate,
Yes.
you can locate the trachea with a central node. I should then mention it here. Yeah, please go on.
Coming to systemic examination, cardiovascular system, yes when yes to heard, no murmurs. Respiratory system, bilateral normal vesicular breath sounds are heard with no added sounds. On per abdomen, abdomen is soft, non-tender, and bowel sounds are heard.
Any neurological? Did you test for the reflexes? Did you test whether she's got proximal muscle weakness? You have to do that, okay? What happens to the reflexes here? Rachna, what happens to the
exaggerated reflexes, sir.
So, which reflex do you usually test?
Knee jerk or brachioradialis.
An EG pass.
Okay, knee jerk.
Knee jerk.
How do you test for proximal muscle weakness?
Patient is not able to lift her hand, sir.
No, that's not.
Proximal muscle.
Yeah. Right. If you
climb
ask
the
her to
stairs, patient is not able to climb the stairs.
More important, can she get up while squatting? After squatting, does she need any help to get up? Okay. You said the patient has got anxiety. How do we distinguish between anxiety and hyperthyroidism?
If it has to open, it will open. If it is safe.
Rachna, could you understand?
Yes, sir.
Tandan, yeah. Rachna, yeah. Could you
Yes,
understand what I'm asking?
Yes, sir.
Okay. In anxiety, the palm will be sweaty and cold. While in hyperthyroidism, it will be sweaty and warm. Otherwise, all features would be there. Tachycardia and sleeplessness would all be there. This is one of the features. Okay, you're done. Can you summarize? Sorry, I spoke before. Can you summarize it for the benefit of everyone?
Before you go, I just want to make one comment.
Yes, sir.
Your patient has got eye signs, correct? No.
Yes, sir.
So your patient is thyrotoxicosis. So in all this situation, you should mention, I will explain the eye signs after the examination of the thyroid swelling rather than general examination. See, it should not become a general. You know, general means just have a look at it and say she has got some prominent eyes or something like that. So what we expect you to mention is in the general examination after mentioning tachycardia, tremors definitely you can mention there because it's a part of it. You will always examine the oral cavity. Once that is done, you also should have mentioned about the edema, you know, pretibial mixed edema. You know, sir asked you sometimes in the general physical examination about the nails. You, instead of mentioning cyanosis, you should have mentioned no clubbing. We will give you more marks in this, especially a case like this, where you suspect thyrotoxicosis. At the end of the examination of the thyroid, then you say, I have examined now for the eye signs, right? How do you examine for the eye signs?
Eye signs, there'll be lid retraction, sir. The limbus will be visible, the upper lid will be retracted and the limbus will be visible, sir. And there'll be lid lag, sir. On asking the patient to move downwards, sir, there will be lag of the upper eyelid, sir, to move with the eyeball. And the patient may have also signs of ophthalmoplegia, sir, muscle paresis, weakness, sir. Usually, most commonly, superior rectus, lateral rectus, and inferior oblique muscles. There'll be weakness of the muscles, sir. Then patient will a Mobius sign, sir. Patient cannot converge has difficulty in converging the eyeballs, sir. And the patient has Geoffroy sign, sir. It means there'll be absence of wrinkling of forehead.
Okay, there are many eye signs are there, but I want you to understand one common question which is asked is, what is Nafziger's method of examination? What is Nafziger's method of examination? That is what I wanted. What is Nafziger's method? So you need to go behind the patient, understand, and look at the superciliary arch. Normally, you will not see the eyeball. If the eyeball is prominent, that means patient has got exophthalmos. See, that's what is your two signs in your patient, no? You showed that photograph.
Yes, sir.
She's got a very prominent eye, correct? So what you should mention is, at the end of your clinical examination of thyroid, I have examined for the eye signs separately. Very important. Once that is done, already mentioned to you about proximal muscle weakness and etc. And then go for others, right?
Yes.
Good evening, Dr. Ajay Khanna, sir. You are joined now.
What,
Sir,
what are your various ways to examine the exophthalmos?
One is on standing behind the patient, sir, and
That is the Nafziger method. Okay. Yeah.
And there is tangentially observing the patient, sir,
Yes.
from the sides.
There is some disturbances there. Yeah. Yeah. Please, Prashna, carry on.
Yes, sir. The other method is tangentially standing, sir, examining the patient from the side, sir. If there is a proper exophthalmos, sir.
And third, so you examine from the back, you examine from the side, but the most important
from the front, yes, from the front, sir.
From the front. And you said that the limbus is visible. Normally the limbus is visible, but you will say that the limbus is visible all around.
All around.
Okay, because upper limbus is not visible.
Not visible.
Okay, so in the case of the exophthalmos, the upper limbus is visible. Okay. Which carotid did you feel in the neck?
Yeah, you said your patient has.
Yes, sir.
Rachna, which carotid have you felt in the neck?
Common carotid arteries.
What other carotids you can feel in the neck?
External carotid arteries.
And internal carotid?
No, sir.
Where do you feel the internal carotid? If you have to feel the internal carotid, where you will feel it?
What is the relation of the thyroid carotid artery with the thyroid gland?
It lies posterolateral to the thyroid glands.
What is clinical significance?
Sir, in thyroid swelling, sir, the carotid artery may be pushed, sir. And in malignancy, sir, there will be infiltration into the carotid sheath, sir. In that case, we might not be able to feel the palpations of the carotid arteries.
Internal carotid artery is felt in the tonsil fossa. Okay, if you have to feel the internal carotid, it is felt in the tonsil fossa.
Okay. That's now you said your patient has lid lag and lid retraction. Can it get in the secondary thyrotoxicosis of the eye sign? Can it present in a secondary thyrotoxicosis?
It can present. Mainly it is seen in
Yeah, these
primary
are the two
thyrotoxicosis.
signs can present, but any signs due to the sympathetic overactivity will be
Yes.
due to the nuclear.
Hello.
Yes, sir.
One advice to you,
Yes,
sir.
not to mention the name, but to mention what the sign does.
Yes.
Okay, that is better.
Yes.
That is a better way of approaching. And thyrotoxicosis, the eye signs are divided into those because of the altered physiology and those because of the altered anatomy.
Yes.
Okay, primary thyrotoxicosis has both altered anatomy because there's a deposition of mucopolysaccharides.
Yes, glycosaminoglycans.
Yes. Whereas physiological eye signs occur because of the, like Sir said, Jailal Sir said, sympathetic overactivity. So you do get in secondary thyrotoxicosis some eye signs. Okay, might not get that classical, that exophthalmos. Classical you won't get, right?
Yes.
What is malignant exophthalmos and what is management for that?
Malignant of exophthalmos, orbital decompression is the treatment, sir.
But what is malignant exophthalmos? Okay, proceed.
Your patient had 2 years of anti-thyroid drug. Do you expect the eye signs to be in the response to that? Normally eye signs will be not respond. In a case of Graves' disease, you are giving anti-thyroid drug.
Normally they respond.
They will respond. So they will not, normally you will not get the response. No? This is a normal phenomenon. You don't get the eye signs to be batch. Okay, go ahead with the management, how you are going to proceed.
Yes. 53. I would like to summarize. 53 years old female who is a known case of hyperthyroidism on anti-thyroid medications, presented with painless progressive swelling in front of the neck since 2 years. On examination, a swelling of size 6x4 centimeters noted in the anterior aspect of the neck, extending from thyroid cartilage up to 2 centimeters above the suprasternal notch vertically, and anterior sternocleidomastoid up to the anterior border of sternocleidomastoid on either side, with nodular surface with well-defined borders moving with deglutition and firm in consistency.
Can I add one thing?
Yes, sir.
Rachna?
Yes, sir.
No, it is always important that in these conditions of multinodular goiters and long-standing thyroid, you mentioned the obstructive symptoms as well. That is very mandatory.
Yes,
you not mentioned anywhere any obstructive symptom. At least you can give it in the negative history. That means the symptoms of the thoracic inlet syndromes, or stridor or dysphagia, that is important. Long-standing goiter, multinodular, and here there is so much of this obesity also. So obstructive symptoms is important.
Yes.
But just saying extending from the thyroid cartilage is a broad structure. So you say it's the upper border of the thyroid cartilage rather than just saying the thyroid cartilage, extending from the upper border of the thyroid cartilage.
Yes.
Okay.
Diagnosis.
Yes, I'd like to give a diagnosis of toxic multinodular goiters.
You started with the primary thyrotoxicosis. Now suddenly you are coming to the toxic multinodular goiter. You said that 2 years back she was diagnosed as a Graves' disease with ophthalmopathic symptoms. Put on drugs. That is as per your history. That is what your presentation. Suddenly you are coming to the multinodular goiter with toxicity. You are talking about the secondaries or anything. Can you get in a Graves' disease also? It can turn to the multinodularity.
It may so have happened, so the patient might have, the unswelling might have gone unnoticed, sir, and she might, when patient present had symptoms.
No, your patient has a very typical eye signs, which is very particular of the Graves' disease. You are very well, the proptosis is there.
Yes.
So definitely this is started with the Graves' disease. Now, can you get a nodularity in a Graves' disease?
Yes, yes, sir. Due to fluctuation in the TSH levels, patient can have progress to have multinodular goiter, sir.
So patient can have presence of one or two nodules. You can't say multiple nodules. One or two nodules in a disease, diffuse goiter, is not a thing to say. It is not a great disease. So don't try to change that. Your diagnosis, if you are changing now to toxic multinodular goiter, that gives a secondary thyrotoxicosis. So that you have to explain a lot.
Do you this is just to know some other diagnosis. Do you think it's Hashimoto's thyroiditis with thyrotoxicosis?
In Hashimoto's thyroiditis, sir, the gland may not always be palpable.
No.
No, it can be palpable, very well palpable.
You can get all types, lymphocytic thyroiditis or Hashimoto's. You can get unilobar, bilobular, smooth, nodular, regular, irregular, asymmetrical, all combination possible. What is the age of your patient?
53 years.
53. Does she fall in the category of that kind of a thyroiditis disease, yes or no?
Younger
what is the doubt? Hashimoto's thyroiditis, what is the age group? Perimenopausal, right?
Perimenopausal.
Whatever. You can expect that this age group. The symptoms started only 2 years, correct?
Yes, sir.
What is the natural behavior of a multinodular goiter going in for a toxicity? What is the natural course? When do they get the usual nodules, etc.?
Sir, tell me, due to fluctuating.
No. I didn't ask you the TSH fluctuation. What is the age group roughly?
How long it takes? What is the timetable? Timeline?
Roughly.
1 year.
No. Question of 1
year.
year.
Only you don't get.
Is what I wanted to answer is it is around a third decade or fourth decade, like that it goes. It doesn't go suddenly at the age of 52, somebody coming with a thyroid swelling to make it as a multinodular goiter. Yes, it's some of the examiners may not like you to answer Hashimoto thyroiditis a differential diagnosis because they know that you have seen the case. But if examiner asks you what other possibility, then you may have to say because of the age and duration of only 2 years at this age group, I have considered the possibility, and she was put on whatever the anti-thyroid drugs or something like that.
I have a counter view.
Yes.
My teacher here. She is also my student, sir, undergraduate. So my
counter
view is your Hashimoto's thyroiditis will burn out, no? Will become hypothyroid within a certain frame of time. This is 2 years history, right?
Yes.
Hashimoto's goiter will take 2 years. To burn out, no. It burns out in 6 to 7 months, probably. It's a rapid burnout. It has a transient
and with the anti-thyroid drug, it will burn out very quickly.
Yes, and no eye signs in usually in Hashimoto's.
That is what I want you to answer. You understand? When the examiner asks you, you say something and then say eye signs. This is one of the important features here. Another way is also, it can still be a primary thyrotoxicosis. There is no rule that it should be seen only in 20 years, 25. Some triggering would have happened, triggering factors. Some viral fever or something would have triggered, might have started with that. And with the anti-thyroid drugs, surface would have got some changes into nodularity. That is also a possibility. You should be able to discuss that in the examination.
One more thing, Rachna, the multinodular goiters are because of iodine deficiency. As a consequence of that, they'll have a long course. They start with the hyperplastic goiter, then colloid goiter, then multinodular goiter. Then it'll be a long history. It won't be like this. And why do you get nodules? Because of what? In a primary thyrotoxicosis.
There'll be diffuse hyperplasia of the follicles.
Medication, what the patient takes.
Sorry, sir?
Is it something to do with the medication, what the patient takes, long-term medication?
Patient will be on anti-thyroid drugs, sir. So the TSH levels will fluctuate and there'll be hyper and both hypofunctioning nodules.
Certain areas. Involution
certain areas,
area, so that they become nodules.
Yes.
Okay. Go on, go on.
Now, how you are going to manage?
I would like to proceed by getting a thyroid function test, sir. Her TSH is less than 0.005 micro international units per ml. T3 2.12 nano moles per liter, and T4 78.73 nanomoles per liter, sir. I would like to go ahead with the ultrasound of the neck. Ultrasound of the neck shows diffusely enlarged thyroid gland with altered echo texture and increased vascularity with multiple well-defined, wider than tall echogenic lesions, both solid and cystic, largest measuring 1.9 cross 1.1 centimeters. There's no evidence of cervical lymphadenopathy. The impression were features suggestive of multinodular goiter. The FNAC of the swelling in front of the neck showed features of nodular goiter, Bethesda category 2.
One more test, Rachna, you could have done. The blood test is the anti-TPO antibodies, anti-TPOs. Now that will help you to differentiate between primary
and secondary.
I want you to also mention here that a preoperative or before doing FNAC also, you used, if I'm not wrong, you said her pulse was 110 or something, correct?
Yes, sir.
So it's better that you say that you will control the toxicity well before even inserting a fine needle aspiration cytology, especially thyroid. Thyroid can have really bleed, especially in cases of vascularity. So what did you do in the hospital after this patient admission simultaneously as you see this investigation? What treatment you give?
We started her on anti-thyroid, sir, tablet carbimazole, sir. It was TID and it was tapered.
She's on carbimazole for 2 years now. Still you want to, are you trying to give the same drug or you want to change the drug? You are satisfied with the first line of therapy or you are wanted to change the drug and try something else?
What's the answer you can give? Is this 2 years treatment given by you or somebody else? That's the first thing you have to answer. What is the dosage which she has received? 2 years. 2 years.
2 years.
Okay.
Initially, it was 30 mg, sir, TID, sir. Then it was tapered for 10 mg BD, sir. Based on her thyroid function test, sir, we took an endocrinologist opinion, sir, to titrate the dose.
We are not getting a picture. The patient is on that. You are. My question is, you are satisfied with the drug. You want to just change the dose. That way, you are reduce the dose. But the patient is not responding. Still, he has all the problems of thyrotoxicosis. In that case, are you justified in go ahead with the same drug, or you want to change to any other drug other than this routine drugs which we give?
This propylthiouracil. But it is, since it is
please, propylthiouracil is a very highly toxic drug. Unless it is very specific. The indication of propylthiouracil is only thyroid storm. Not even for pregnancy. Now pregnancy, unless it is the first trimester pregnancy, propylthiouracil is not a drug of choice.
Yes, sir.
The second trimester and third trimester still use methimazole and carbimazole. Propylthiouracil, the indication is only thyroid storm or first trimester pregnancy. So don't use that drug. Any role of lithium, any role of reserpine, other anti-thyroid drugs?
Lithium, we don't use it nowadays, sir, because of the lithium toxicity, sir. So carbimazole is the drug of choice. Then
okay, go ahead.
We did an indirect laryngoscopy, which was a normal study. Her 2D echo was normal with ejection fraction of 60%. A chest X-ray with AP and lateral neck X-ray view, they were normal. There was no tracheal deviation seen on chest X-rays.
Go ahead. So what is your plan? How you are going to proceed?
We would like to, once the patient is euthyroid, sir, we would like to go ahead and do a total thyroidectomy.
How long you are going to wait to become a euthyroid?
Ideally, sir, the patient should be in euthyroid state for 10 weeks, sir, but we can, acceptable is around 6 to 8 weeks, the patient should be euthyroid, sir, before going ahead with the surgery, sir.
No, I mean, you want to say that the past history of 2 years is different. Now you are starting a fresh line of drugs, and so that you have to wait for another 6 weeks.
Yes, sir. The patient, because the THS is still on the lower side, sir, less than 0.005.
Rachna, have you considered anything other than are you considering any surgery?
Yes, sir.
Any other option than surgery?
But multinodular goiter surgery, so the other option would be radioactive ablation, sir. But due to
Rachna, what is the role of radioactive iodine scan and role of radioactive iodine in the treatment?
Usually in Graves' disease, sir, the ones following anti-thyroid drugs, sir, radioactive ablation ablation therapy is used, sir. It is used mainly in Graves' disease. In thyrotoxic process, usually they do not respond to the anti-thyroid drugs, sir, multinodular goiter. So surgery is the best available option.
What is the role of a scan, radioactive isotope scan,
Yes,
and
sir.
which is used for the scan, and which isotope is used for the treatment?
Yes, if a patient is presents with a swelling with features of hyperthyroidism, sir, we do a radioactive radioisotope iodine scan, sir. Iodine 123 or technetium 99 can be used, sir.
No, what is used? Yeah, why it is used? Iodine 123.
Because it has a shorter half-life, sir, 12 to 13 hours, sir, and it also has a better resolution, sir. And for as a therapeutic
advantage with technetium 99.
The resolution is lower than that seen in radioisotope iodine.
It is not only taken by thyroid, it is taken by
other tissues.
Salivary glands, other things also will take. So now we don't use 123. It is only theoretical. We have books say 8 hours, but it is not available in. We are only technetium is only used for now for the diagnostic.
You also should have probably told that I would like to add inderol or propranolol in your patient because patient has got tachycardia. You understand? Your patient has got 110 pulse rate. So you could have added, in addition to the carbimazole, that whatever dose which you have mentioned, 30 milligram or 40 milligram, whatever 8 hourly dosages, I will start the patient on propranolol and watch for it. You don't have to go for another 6 weeks again now. Actually, if you manage with the propranolol for another week or so, then you can probably look at the TSH values and then take a decision. That's what we expect you to say if there's a tachycardia. If there's no tachycardia, it is not really required. What is the importance of knowing these two drugs? Post-operatively, what do you do after surgery?
Post-operatively, sir, we continue propranolol, sir, for another 10 days, sir.
Slowly taper it.
So tapering the dose, and we continue post-operatively for a period of 10 days.
That is an important thing. You should remember.
Why do you want to continue? Why do you want to continue?
Sir, because the half-life of T4 is 7 days, sir. So there'll be still circulating thyroid hormone in the blood, sir. So propranolol, since it inhibits peripheral conversion of T4 to T3, sir. So we have to continue propranolol post-operatively for a period of up to 10 days.
Good.
Okay, supposing if you are going for radioactive iodine ablation, I mean, just theoretical question. So what precautions you take, and
yes, sir, the patient should. The drugs? Yes, sir, the patient should be on a low iodine diet 2 weeks, sir, and the patient should, we have to maintain the TSH at a higher level, sir. More than 30 milli international units.
That we continue to stop before the radioactive iodine is given.
No, that is for when after total thyroidectomy. What you're telling, no, zero iodine diet and get the TSH up, that is for after you have done the total thyroidectomy. The reason is those secondaries, right? They do not pick up very well. So you want to make them sensitive for the iodine. When the thyroid is intact, any iodine you give will take up immediately. So you don't need any precautions when you are doing a ablation for those.
Antithyroid drugs at least 4 or 5 days before.
What precautions you will take? Actual precautions. You have done that test already. You have done that investigation. Why did you do the echo?
To cardiac status.
Yeah. If the cardiac ejection fractions are not up to the mark, one should not do iodine 131 ablation. Okay. And it's a myth that you can't do iodine 131 ablation in a secondary thyrotoxicosis. You can. The difficulty is to calculate the right amount of dose, but the technical problem has been overcome now. We have a series where we are done for secondary thyrotoxicosis. Actually, it's my cases, but done in Manipal actually, because we didn't have iodine 113 ablation. Yeah, it's to send it to Dr. Rajesh. I don't think he's there anymore in Manipal, but he was doing even for secondary thyrotoxicosis successfully. Okay.
What surgery you're going to do?
Sir?
What surgery for this patient?
Total thyroidectomy.
How would you manage post-operatively?
Post-operatively, patient should be continued with the propranolol for a period of 10 days, sir. And since the patient should be supplemented with levothyroxine, sir, from post-operative day.
The dose of levothyroxine?
Yes, it is 1.6 microgram per kg per day, sir.
Yeah, and how do you follow up these patients?
Yes, patient should be started on levothyroxine, sir, and repeat the thyroid profile after 6 to 8 weeks, sir, and titrate the dose according to the TSH value based on the TSH values.
Yeah, that's right. I think we're getting the message.
Rachna, you are preparing the OP list for this patient. Your consultant in charge is going to operate 5 patients on the next day, and this is one of the patients. So how will you make your OT list?
We put this patient first on the list, sir.
Why first on the list?
The patient, because the patient will be anxious and restless, sir. So, since it's a clean surgery, sir, and the patients will be anxious, the hyperthyroid patients.
That is one of the most important.
Making them wait for a.
And then the surgeon is also very anxious, you know.
When you told you will put it in the list, I was very happy. But answer you gave was not correct. Somebody is
anxiety in thyroid is entirely different from anxiety we get in other surgery. No? It is not a stress-induced anxiety.
Imagine any complication for which you should know. You should be available there, observe for a few hours. What is that? That's what I think sir wants.
Yes. There are several reasons. That is also one of the reasons, You are right in saying about the anxiety of the patient, but mainly it is to see the patient after the surgery. Exactly. Now, when you are operating this patient, it has to be really had a good observation in the post-operative period. So you require a good time for that purpose.
And your patient is also a diabetic patient.
Yes, sir.
So that automatically puts the patient over the.
So this is also a time when they will ask types of hemorrhage: primary, reactionary, and secondary. So the area of reactionary hemorrhage is something which you can watch say you are done a thyroidectomy, 9 o'clock you have started, say 11:30 you have finished. So 6 hours, at least till your list is over, 5, 6 hours, the crucial time in which it can happen. Secondary occurs later. Primary, which is under your control. So that's one of the things which probably examiners expect.
Now, at the time of the surgery, Ratna, you are not sure whether you have removed all the parathyroids or not. What can you do at the operation? How will you check that the tissue which you have removed is not a parathyroid?
The whatever tissue we have removed, sir, we put it in
it is confused with which structure?
Adipose tissue, sir. Adipose tissue.
So how will you differentiate whether it is adipose tissue? You have removed that structure, but you want to make sure whether it is adipose tissue or the parathyroid.
The parathyroid is sink to the bottom, sir, when placed in a glass of jar of normal saline, sir, whereas the adipose tissue floats, sir.
It will not sink to the bottom. Okay. Adipose tissue will float.
Yes, sir.
While parathyroid will remain in between. It will not sink to the bottom. Yes. But if you are thinking about a parathyroid adenoma is there, then that will sink to the bottom. Okay. The normal parathyroid will be in between. Any other ways intraoperative that you can know that this is a parathyroid, apart from looking at the anatomical structures, the type of the parathyroid which is there? Can you do any dye test to know about the parathyroids? Okay, you can inject the methylene blue. Okay, that is one. And second is the indocyanine green. So these two dyes which are there, which you can inject and you can find out that that particular tissue which is there is a parathyroid. Okay. Can we stop now for this patient?
How will you manage post-operative hypocalcemia?
Usually
how will you recognize it and how will you treat it?
Yes, usually hypocalcemia presents postoperatively on between day 2 to day 5, sir. Day 5, ma'am. We do a Chopsticks test, tapping in front of the external auditory canal, and there'll be a muscle twitching noted if the patient is the serum calcium hypocalcemia, and we do a Trozius test, sir.
Before you carry out all this, what is the first symptom
the patient will
have?
The perioral numbness. Patient will have perioral numbness, tingling, and numbness in the hands with perioral numbness.
How do you do the test?
Chopstick is tapping in front of the external.
You explain the next one.
Trozius test is inflate the BP cuff 30 to 40 millimeters mercury above the systolic blood pressure and wait for 3 to 5 minutes. The patient will go in for carpopedal spasm if there is a hypocalcemia.
How will you manage this?
We can patient can be started with given IV calcium gluconate. It is given 10 ml of calcium gluconate in 100 ml of normal saline over 10 minutes, or and patient can be given oral calcium supplements. If the calcium is less than 7 grams, we usually go for IV calcium gluconate. If it is between 7 to 9, we give oral calcium supplements.
How do you withdraw the blood for the calcium?
We should not squeeze the hand before drawing the blood.
Okay, no tourniquet, no squeezing.
No tourniquet and no squeezing the hand before drawing the blood.
Well done.
Dr. Gurushantapa, sir, do you like to give closing comments, sir?
Nothing, sir. Nothing. There are a lot of good questions. I think she has learned many things from different examiners. Here and there, in spite of our instructions, she went little away and did mistakes. But overall, it was okay, sir.
Thank you very much, sir.
Thank you, sir.
Professor
Thank you for the
Shabi Ahmed,
opportunity given to her, sir.
sir, you would like to give your comments, sir?
Yeah.
Sir, I think you have some connection challenges, sir. Are you okay, sir? Okay, let sir come in. Anyway, he's going to stay with us for the next case. Satish, do you have any questions to be asking? You want the doubts to be clarified? Dr. Achana, Satish?
Yes, sir.
Do you have any doubts you want to clarify with the national faculty? Thank you very much, ma. Good luck
Thank
to
you,
you.
sir.
All
Thank
the
you.
best. Thank you, Guru Shantapa sir, for permitting your PG to present the case here. Thank you very
I
much.
would like to thank my HOD Guru Shantapa sir for giving me an opportunity to present the case. Thank you everyone for the
Good luck
opportunity.
to you. Good luck to you. Now, can I invite the student contributed by Professor Rajavelu sir from Vellore Medical College, Dr. Parthi.
Good evening, sir.
Please
there is
share your
some connection
PowerPoint and
problem
start
on
your
my end.
presentation, Dr. Parthi. Shabi sir, Rekha ma'am, Dr. Srinivas sir, and other faculty kindly take over.
Is it?
Good luck to you, Dr. Parthi. All the best.
So good evening, sir. So is it visible, sir? Am I audible, sir?
You are perfectly okay. Go ahead.
Yes, sir. So good evening, sir. Good evening, respected professors. And so I'm presenting a case of a breast lump, sir, under the guidance of my Professor Rajavelu, sir, and my unit chief, Professor Manikanan, sir. So a 58-year-old female. Sir, can I go ahead, sir?
Yes.
Please go ahead.
Yes, sir. So a 58-year-old female, Mrs. X Muktarapadi, a homemaker of occupation of a low socioeconomic group, came with the chief complaints of lump in her left breast for the past 10 months and ulcer around her nipple for the past 2 days, past 2 weeks. Sir. The history of presenting illness, patient was apparently normal 10 months back. She noticed a small lump in her left breast in the upper outer quadrant, which was about 2 cross 2 centimeters in size. Insidious as someone said. It is gradually increasing with a sudden increase in size for past 1 month. Sir. She noticed an ulcer in her left breast around the nipple areal complex for the past 2 weeks with erythema and crusting. And she complains of pain over the lump for the past 1 week after an attempt of after a biopsy. Sir. And there was a serosanguinous discharge from the ulcer since 1 week. Sir. There's no history of any nipple discharge or no nipple retractions. No history of any other lump in the other breast or in the either axilla or in the neck. No history of trauma to the chest wall or fever. There's no history of any bone pain or cough or breathlessness or no history of jaundice. No history of pain, abdomen or distensions. No history of headaches or seizures. Hello, sir. No history of any comorbidities. There no history of any comorbidities. And diabetes or hypertension, coronary arteries, COPD. There's no issue of any oral contraceptives or hormone replacement therapies. Sorry, sir, am I audible, sir?
I would recommend you to remove your headset and present party. Please disconnect it from your device. No, please disconnect the headset from your device, Parthi. Or use your headset. We are unable to hear you at all.
Hello, sir.
Yeah, you are okay. Please go ahead.
Sorry, sir. Shall I start from beginning or?
Please start. Please start.
Yes, sir. I'm presenting case of breast lump under the guidance of my professor Rajavelu sir, and my unit chief Professor Manikan sir. So, 58-year-old female, Mrs. X from Torapadi. She's a homemaker by occupation of a low socioeconomic group. Came with a complaint of lump in her left breast, around the nipple for the past 2 weeks, sir. Am I audible, sir?
You're okay, ma. You don't keep meddling with your device. You're going
Okay,
good.
Yes, sir. So, issue of presenting illness, patient was apparently normal 10 months back. She noticed a small lump in her left breast in the upper outer quadrant, which was about 2 centimeters in size, which was insidious as onset and gradually increasing in size with a sudden increase in size for the past 1 month. And she noticed an ulcer in her left breast around the left nipple areolar complex for the past 2 weeks with erythema and crusting. Complaint of pain over the lump since 1 week after a biopsy, sir. And there was serosanguinous discharge from the ulcer since 1 week. There was no issue of any nipple discharge or retraction. No issue of any other lump in the other breast or in either axilla or in the neck, sir. There was no issue of trauma to chest wall or fever. No issue of bone pain, cough or breathlessness. No issue of jaundice or pain abdomen or distension. No issue of chronic headaches or seizures. No issue of comorbidities like diabetes, hypertension, coronary artery disease, or pulmonary tuberculosis. No issue of oral contraceptives or hormone replacement therapies. No history of radiation exposure. No history of previous investigations or interventions to the breast. And on personal history, she consumes mixed diet with normal bowel and bladder habits. Sleep and appetite were normal. No history of consumption of alcohol or tobacco in any forms. The menstrual and obstetric history. She attained menarche at the age of 15 years, and she's nulliparous and she's unmarried. Had regular menstrual cycles of 3 to 4 days of a 30-day cycle. No history of menorrhagia. They attained menopause at the age of 48 years of age. There's no history of carcinoma breast in any members of the family from either a maternal or paternal side. No history of any other malignancies among any members in the families. In summary, a 58-year-old postmenopausal nulliparous woman with the complaints of lump in her left breast for the past 10 months, with rapid increase in size since 1 month, with ulcer around the nipple areolar complex for the past 2 weeks, with pain and serosanguinous discharge for the past 1 week. With the given history, I would like to examine the left breast for a possible malignancy. Hey, continue, sir.
Faculty, kindly take over. Please wait, Parthi.
Yes, sir.
Rekha Madam, Jailal sir, Shabi sir.
Yeah. I just have one observation to make.
Okay.
But
Yes, madam.
when you're presenting,
Yes.
when you're presenting, one other detail that you could add is the BMI as well. All right. You were talking about the general examination. One,
No,
you can
I
have.
haven't. I'm yet to come, madam, for the general examination. It's just a history, madam.
All right.
Yeah.
All right. Okay,
Yes.
fine.
Yes, yes, ma'am. Shall I proceed, ma'am? Yes.
You have elicited some history. In
Yes, sir.
your history, what were the predisposing factors or it is responsible for developing a cancer, which is makes the patient?
Yes, so there's a rapid increase in size for past 1 month. The patient is
No,
telling,
I'm not
sir.
asking the history. What are the criteria, risk factors in the history
Yes,
you
sir.
have elicited?
Yes, sir. She's a nulliparous woman, sir, and post-menopausal nulliparous woman.
Why nulliparous woman is more prone for? Is it nulliparous woman is more prone for malignancy?
Yes, sir.
Why?
So there's unopposed estrogen action, sir.
Where is unopposed estrogen action? Every
Sir,
menstrual
pregnancy.
cycle has a estrogen and progesterone.
Yes, sir. So during pregnancy and breastfeeding, the estrogens are suppressed to a level, sir.
What is the reason you can find to make sure that is for a nulliparous woman is more prone for pregnancy? There are various reasons cited,
Yes,
but there is no concrete evidence. What are the types of what is the terminal, functional unit of the breast which develop into malignancy?
So mainly ducts, sir. Duct.
What is that duct? Is it the duct is going to be that? What is TLD?
So terminal lactiferous ducts.
Okay,
Sorry, sir.
So what are the types you have? What is type 1, type 2, type 3? So we must go and read that because type 1, type 2, type 3.
Yes,
type 1 is in the pre-menarche period. Type 3 is after the delivery. Type 2 is a period where the sexual changes taking place in the breast will make non-responsive to the estrogen. So that period is a protective period when the patient when the breast goes through the stage of type 2.
Yes,
so they are more protected. It is not that estrogen excess. It is they make the sensitivity of the uterus, the estrogen on the terminal ductules or
Yes,
that is the one reason. So your patient has nulliparity.
Yes.
What are the other risk factors your patient has?
Other than that,
you said your menarche period is 15. Age is 15, no?
She's 58 now, sir. She attained menarche at around 48 years, sir.
No, menopause at 48, menarche at 15.
15 years, sir.
So what is the importance of that?
So early menarche is a risk factor, sir. Early menarche before 12 years of age.
No, why it is a risk factor?
Again, estrogens stimulating the breast, sir.
That is estrogen is a good word. You can use anything in the breast, but you must explain how the estrogen is there. Why estrogen is excess? What type of cycle you get in the early menarche?
Usually, to start with the irregular, frequent cycles.
Why?
For that, the hypothalamic axis to stabilize.
Very, very good. It is takes an anovulatory cycle, so you will have a continuous estrogen will be there.
Yes, sir.
So what is the period of menopause you will mean?
More than 55 is a risk. More than 55 years of age is a risk factor, sir.
So your patient has at the 48.
48, sir. Yes, sir.
So how will you, in a patient is given, can you assess any module by which risk factors for a patient? You know any scoring system?
Yes, sir. There's a Claes model, Gale model and class model, sir. Gale model utilizes age and age of the patient, age at which she attained menarche, and about the age of a first child.
What is an absolute risk factor and modifiable risk factor?
So modifiable risk factors are age at first birth, childbirth, sir, and hormonal therapies, hormone replacement therapies, smoking, alcohol. These are all modifiable.
Non-modifiable risk factor.
Non-modifiable are again this patient sex, ethnicity, and hereditary and genetic predispositions like the BRCA and BRCA1 and 2 mutations. These are all not modifiable risk factors, sir.
Okay. The only thing in your history you have put as a nulliparous and unmarried. It is better to put as unmarried and nulliparous.
Sorry, sir.
Parous and it's a two. Okay.
Sorry, sir. Sorry. Taken. Yes.
Okay. Okay.
Shall I proceed, sir?
Otherwise, your history is perfect. You have asked almost all the things. And
Yes, sir.
what are the metastatic history you have asked?
Sir, as for bone pains, sir, breathlessness.
Which bone pain? Which bone pain?
So mostly in the lumbar, low back aches, sir, and ends of long joints, long bones.
Why do you ask for the lumbar bone?
Sir, the metastasis via the Batson plexus, which are valveless veins, is more common.
No.
Is the most common.
What is the relation? What is the relationship of Batson plexus and the breast?
So the lymphatics drain into. I mean, Batson plexus are valveless paravertebral vein in venous systems.
I agree on that. Batson plexus extend from where to where?
So it's a paravertebral venous system, and the lymphatics drain.
No, venous. You don't confuse. It is a venous system. Don't put the lymphatic system to there.
Okay, sir, sorry.
No, how from the breast, the blood goes to the Batson plexus. Breast is not drained by the Batson plexus, no?
Yes, sir. The intercostal veins.
How many intercostal veins are there?
Batson.
How many intercostal veins you have?
Sorry, sir. Not sure, sir.
How many intercostal veins? Okay, there is 11 intercostal veins and one subcostal vein.
Okay, sir.
So you should don't say it is like an undergraduate saying that breast it to the Batson plexus. We must know how it is going from the breast to the Batson plexus. Batson plexus is only a paravertebral venous plexus, so it is nothing to do with the vertebra. How it goes from the Batson plexus to the vertebra and where the lesion comes.
Yes, sir.
And why do you get the pain? So all this is important. What type of lesion it will produce?
Osteolytic lesions, sir.
Okay.
Mostly.
So what is the next site other than lumbar vertebra?
Next is lungs, sir. Lungs, patient might have breathlessness.
No, in the bone. Which bone? Which bone?
After that, femur, ends of femur, sir. Femur, thoracic vertebra, ribs, skull.
Which portion of the bone the second piece will go? There's a diaphysis, metaphysis, and epiphysis in the bone.
Usually to the epiphyseal regions.
Why?
Of the rich venous
You are
plexus.
right,
Rich blood
so that
supply.
is a growing end.
Growing end.
Okay.
Yes.
So that the history you should talk because just you are asking about the backache.
Yes,
most
sir.
of the lady is complained of backache. You must say the recent onset of the back pain or
Yes,
recent onset of whatever is there.
Yes,
particular way you should do. You are okay.
Yes, sir.
Go ahead and the clinical examination.
Yes, sir.
Even what are the various absolute risk factors and what are the various relative risk factors for the cancer breast?
Sir, absolute. The absolute risk factors.
You are just now you answered Parthiban, so you must.
Yes, a modifiable and it's a age and early menarche and late menopause, nulliparity, and family history and hereditary predisposition.
No, but you know what is the difference between absolute risk factor and what is the relative risk factors?
Absolute or like a definite, like a 100. Most likely.
There are only 5 or 6 absolute risk factors.
Yes, sir.
There are about 50 relative risk factors, but
Relative.
only 5 or 6 are the absolute. So can
Yes,
you tell
sir.
what are those absolute ones? Age of the patient.
Age of the patient, sir. And
family history.
Family history.
If the patient already has suffered from one side cancer.
One side breast, yes. One side breast, the other side is mostly.
Is something specific benign breast disease operated in the past and comes out to be a?
Yes, sir.
What type of the histology it will be?
Sorry, sir. Okay.
A patient has been operated in the past
Yes, sir.
for a benign breast disease and
Yes,
the
sir.
biopsy report is, that is also an absolute risk factor. So can you
Yes,
tell
sir.
which is that biopsy report?
You have an IND or fibroadenosis.
Atypical ductal hyperplasia.
Atypical ductal hyperplasia, atypical lobular hyperplasia, proliferative.
And if the BRCA1, BRCA2 are positive.
Yes, sir.
These are the only 5 or 6 absolute respects.
Absolute respects. Okay, sir.
All those others which are there, like the
Yes,
nulliparity, early menarche, late menopause,
yes, sir.
lactation, feeding,
yes,
obesity, alcohol,
yes,
smoking, all those are the relative risk factors.
Yes, sir. Yes, sir.
What is the tumor doubling time for a breast cancer?
Sir, to start with, initial replication, it's about more than a year, sir. Later replications are faster.
No, I'm asking the tumor doubling time means one cell becoming 2 cells, 2 cells
Yes,
becoming 4 cells,
4 cells.
4
Yes, sir.
becoming 8 cells.
Yes, sir.
What is the tumor doubling time for the breast cancer?
5 years to start with, sir.
No, it is about 100 days.
100 days.
It's
100
approximately
days.
100 days.
100 days.
So for becoming a palpable 1 centimeter tumor, it takes around 5 years,
5 years,
from
yes,
one
sir.
cell
Yes, sir.
to become a palpable 1 centimeter.
Okay, sir. Yes, sir.
Okay.
Yes.
Almost 30 cycles it has to undergo to become almost 1 centimeter, say.
Okay, sir.
Fathiman, you said alcohol and obesity. What is
Yes,
the
sir.
risk factor it has for the breast?
Alcohol, it increases the sensitivity of breast tissue estrogen. And
Very good.
obesity is more of a fatty tissues. Adipose in post-menopausal women, fatty tissues are the source of estrogen. The androstenedione converted by aromatase inhibitors to estrogen in the fatty cells, adipose tissues.
Good, good. So that is by the peripheral conversion. That is
Yes, sir. Yes, sir. And also lack of physical activities and night shifts are given as factors.
And what cycle for doubling time it will start disseminated into the blood metastasis? It takes almost 30 cycles to become more than 1 centimeter, palpable mass.
Yes, sir.
But the dissemination can start much earlier. Even
Yes,
by the 20th cycle itself, that means even before we start palpating a mass,
yes, sir.
the metastasis can, micrometastasis can go. That is why we say it is a systemic disease.
Systemic disease, yes. Yes, sir.
You come to the
Yes,
clinical examination.
On general examination, sir. Patient is conscious, oriented, and afebrile. So moderately built and moderately nourished. It's no pallor, no uterus or cyanosis, no lymphadenopathy, any cervical lymphadenopathy, or generalized lymphadenopathy. And ECOG score is 1, sir. Height of 158 centimeters, weight 54, and a BMI of 21.6, sir. And vitals were normal, sir. 80 per minute is regular rate, and blood pressure 138 by 80 in right arm sitting posture. The respiratory rate of 16 and normal temperature. And this is the image of that patient, sir. May I proceed with the examination of the breast, sir? So after informed consent, with the due respect to privacy in the presence of a female attender, patient examined in a well-lit room, sir. On inspection, in a sitting posture, on a stool with the arms by a side of a body, the left breast appears at a level higher than the right breast. There's an irregular erythematous swelling of size 7 × 6 centimeter is seen, occupying all the 4 quadrants around the nipple areola complex. And an irregular shaped crusted ulcer is seen over the skin of the swelling around the nipple areola complex. And a pseudo-orange appearance seen in the lower inner quadrant. And a satellite nodule is also seen in the lower inner quadrant. The nipple, there's no discharge or retraction seen. Axilla, no visible lump seen. And supra and infraclavicular fossa, no fullness seen. On inspection with the arms raised above her head, the left breast appears at a level higher than the right breast. On pseudo-orange is better appreciated in the lower inner quadrant with the arm raised. On axilla, there's no fullness seen, sir. On leaning forward, the left breast swelling does not fall forward. On inspection with the arms pressing against a hip, pressing and relaxing alternatively, the left breast lump does not become prominent. On palpation, sir, all the inspectory findings were confirmed. There's no local warmth or tenderness present. Palpatory finding did with a dial clock method with the pulp of my fingers. The left breast palpated systemically from the areola concentrically outwards. An irregular lump of size 7 × 6 centimeters, palpable, occupying all the 4 quadrants around the nipple areolar complex. There were irregular margins with a hard consistency, and skin over the swelling. The pincher inch test is not pinchable. The swelling moves along the breast tissue and across the breast tissues. A satellite nodule was felt in the lower inner quadrant, and palpation with the arms pressed against her lips. The lump moves along the breast tissue and also across the tissue, breasts. On nipple, there was no discharge, no retractions. On palpation of the left axilla, a single mobile node of size 1.5 × 1.5 centimeter palpable in the central group of lymph nodes. Using my left hand, the patient's left hand resting on my my hand, I will to from the in front of the patient. I palpated at left axilla for the anterior and central group of nodes, and it's not tender. On percussion, the parasternal regions were resonant on both sides. On examination of the right breast, it's normal. On right axilla examination, a single mobile lymph node of size 1 × 1 centimeter is palpable, the central group of lymph nodes. May I proceed to the systemic examination, sir?
You complete your examination.
Yes, sir. And cardiovascular systems, S1, S2 heard, normal vesicular breath sounds, and periabdomen, it's soft, it's no organomegaly, there's no mass palpable, no distension of free fluids, there's no focal neurological deficits, systemic skeletal system, no tenderness, perirectal examination and perivaginal examination are normal. And summary, a 58-year-old postmenopausal nulliparous woman with a complaints of lump in her left breast for the past 10 months, with a sudden increase in size since 1 month, with an ulcer over the swelling for the past 2 weeks, with no nipple discharge, with a single mobile axillary node on the left side. On examination of the left side, left breast, a 7 × 6 centimeter irregularly shaped hard lump is palpable around the nipple areolar complex, occupying all the 4 quadrants that moves along with and across the breast tissues with an irregular shaped also the swelling of the skin over the swelling around the nipple areolar complex with a purely orange appearance and a satellite nodule in the lower inner quadrant with a palpable single mobile axillary node in the left axilla. The right breast was normal with a single mobile lymph node in the right axilla. My clinical diagnosis, a 58-year-old postmenopausal female, probably a carcinoma of the left breast, and clinically it is T4B N1 M1 of stage 4. It belongs to the metastatic breast carcinomas.
First, even you are well presented.
Thank you, sir.
So on the, but only thing which was said is the retroalveolar mass. And the ulcer is also around the retroalveolar region. Where is that ulcer and where is the mass?
Sir, the ulcer is present over the mass, sir.
No, mass is behind the lip areola. Where is an ulcer?
The ulcer is also over the nipple areolar over the mass in the nipple areolar complex, sir. With a crusted.
Is it on the inner quadrant, lower quadrant, and which quadrant? It's not going to be on all the quadrants. No, you have said the mass is in all the quadrants.
Yes, sir. The ulcer is again it's in all the quadrants, sir, around the nipple areolar complex. Irregular shaped ulcer.
What is the size of ulcer?
It is 5 × 4 centimeters, sir.
It is something difficult to understand that the ulcer is in all 4 quadrants.
Sir, this sorry, sir. Can I show the pictures?
Okay, fine. You have the screen there.
Zoom. I'll try to zoom it out, sir.
No, it's fine. But we are not seeing
Okay,
any ulcer on the outer quadrant.
Oh, okay, sir.
Okay.
Sorry. Okay, sir.
Okay, you can change the picture.
Okay, sir.
Is the nipple intact or is it destroyed?
The nipple is intact. No discharge. No retraction. No retraction, sir.
The other thing I wanted to ask you is, you said organomegaly, no? I have an issue with people using that word organomegaly. I would want to know which organ, spleen, or is it the urinary bladder, or which organ?
Liver, sir.
What organ do you mean? And it should be very specific. Any other organ?
Sir, I just want to palpate liver and of course adrenals will not be able to do it.
No. See, you want to palpate. Why don't you say there is no hepatomegaly?
No. Okay, sir.
Why do you want to use this medical term which physicians use called as organomegaly?
Okay, sir.
Are you looking for liver enlargement? Are you looking for spleen enlargement? Are you looking for ovarian enlargement?
Yes, sir.
What exactly are you looking
Yes, sir.
for? So I have an issue.
Okay. Yes, sir.
Most of the postgraduates are presenting like this only, organomegaly.
Okay, sir. I'll be specific.
Why you want to look for, what organ do you want to look for and why?
In this case, liver specifically, sir.
Yeah. So please kindly say that, no, in your presentation.
Yes,
I want, there is no palpable liver and there is no other mass. Which other you want to look for?
So being a postmenopausal woman, ovarian is unlikely, sir.
Okay, thank you.
What are the various respiratory findings you can expect in a patient with a cancer breast?
So if there is metastasis to lungs, she may have breathlessness on exertion.
Examination findings.
Examination findings. Respiratory. Normal vesicular bed sounds may be absent, sir.
Why?
More of a bronchial.
Is it going to be the bronchi? The metastasis is going to the bronchi or the parenchyma or periphery?
More in the periphery, sir.
So what will be the clinical feature?
Tell what are the various signs you can expect in a patient with a cancer breast.
Or in simple words, which is the only finding you can accurately diagnose on clinical examination?
Axillary nodes.
No. We are asking if the thorax.
Thorax.
You're talking the respiratory system, is it?
What you can tell with conviction, okay, this finding is there because of the because I examined like this. This is the finding, and therefore the respiratory system is involved. With conviction means you don't need any other proof. You have done the test; those findings will point you toward a certain finding.
Is it radiological tests? Can I?
No,
I mean clinical.
We are just asking clinical.
Clinical, sir.
Parthiban, you know what is the cause of death in a carcinoma breast?
It's metastasis. Metastasis.
No, what metastasis?
So most common is the bone metastasis, sir. But lung metastasis causes death.
No, bone metastasis will not cause death.
Yes, sir.
The commonest cause is a malignant pleural effusion.
Pleural effusion, yes, sir.
So can you find out anything? And what are the various signs are is asking on a respiratory system you will get on a carcinoma breast?
So pleural effusion on percussion. Sorry, sir, I'm not.
You can get in the lung parenchyma, something may be there. You can get something in the pleural cavity. Okay, if there is a metastatic nodule which is there in the lung parenchyma, what it can cause? Or it is pressing over the bronchus, what it can cause? The commonest is the malignant pleural effusion. Okay,
Effusion,
that's the commonest.
Yes, sir. Breathlessness.
It can cause, no, breathlessness is the symptom, you know.
Symptom.
I'm asking for the signs.
Sign.
It's the consolidation.
Yes, sir.
Okay.
Yes, sir.
So you will get the rhonchi, you will get the rays, they will be there.
Yes, sir.
Decreased vascular sound will be there.
Yes, sir.
Evidence of pleural effusion will be there, and evidence
Yes.
of consolidation will be there.
Yes, sir.
Now tell, how will you differentiate? Is it a case of a consolidation or is it pleural effusion? On clinical examination only. Yeah.
Both will have dull note on percussion.
Dull note on percussion. Yes.
So how will you
will
differentiate?
The nature of the breath sounds, sir, bronchial and vesicular.
You will do the vocal fragmentus and vocal resonance.
Okay, sir. Okay.
Okay, that is the only sign which can differentiate.
Yes, sir.
In consolidation, it will be increased, while in case of the pleural effusion, it will be decreased.
Okay, sir. Nice.
What are the neurological findings you can get in a patient with a cancer breast?
You can have headaches, loss of consciousness, maybe even seizures.
The patient has a brain metastasis.
Yes, sir. She can present with headaches, sir.
Examination finding.
Examination findings, sir.
Yeah.
You said the commonest finding is in the lumbar vertebra.
Yes, sir. So, with brain metastasis, if there's a space occupying lesion,
what will happen if there is a space occupying lesion is there? How does that present?
Meiosis maybe there's.
Meiosis.
Sorry, sir.
What are the features of increased intracranial tension?
So bradycardia,
have the headache,
tension.
That is a symptom.
Yes.
The patient will have the vomiting. That is a
vomiting,
symptom.
projectile vomiting.
What is the sign? What is the sign of raised intracranial tension?
Sign.
Papilledema, no?
Papilledema. Okay, sir.
These are three features of the raised intracranial tension.
Okay,
so
sir.
you will get the. So either the patient may have the localizing signs may be there. The patient may come with a hemiparesis or paraparesis, whatever it is.
Okay,
and then the raised intracranial tension. What are the abdominal signs you get in the case of the cancer breast? Just tell me the signs.
Signs. Hepatomegaly, sir.
Right.
Free fluid.
Yes.
There may be in a premenopausal, there could be a ovarian mass can be felt, sir.
It can occur in the postmenopausal also. Okay. That
Okay,
theory has changed now.
Okay, sir.
That it is only because of that. It may occur also in the postmenopausal.
Postmenopausal. Okay,
Much more common in the premenopausal.
Premenopausal. Okay, sir.
The concept of drop metastasis is changed. Now it is really going into the lymphatic. So it can happen at any time.
Yes, sir.
Okay. What else on the abdominal examination?
Free fluids, sir.
That you are told.
Yes, sir. Nodules around the umbilicus, cystogyrum. Joseph.
Yes. Okay. Yes.
Yes.
Why did you do a DRE examination?
Digital exam. I want to rule out other malignancy like colon cancers, BRCA2 associated cancers.
You are not aware of Bloomer's self?
Bloomberg's, yes, sir. Bloomer's self.
So that is the Bloomer cell is a sign of the cancer breast. Okay, so these are the various abdominal signs which you can elicit in a case of the cancer of the breast.
Yes, sir.
When you are doing a digital examination, how will you differentiate Bloomer's cell from rectal malignancy?
Bloomer's cell from the more in the anterior region, sir.
There is no evidence that rectal carcinoma will be in the posterior.
Posterior, I mean, sir.
It can be
It's
there.
a circumferential more. Yes, sir. Rectal. There can be bleeding on the rectal examination, sir. In case of rectal cancer.
So rectal cancer, you will see the mucosa will be eroded. Mucosa will be ulceration.
Mucosa will be
so here the mucosa will be normal.
Intact. Yes.
You will be seeing that nodular only will be things. So
yes, sir.
There is one possibility always when you see that. What will be the clinical features patient will have if he has a Bloomer cells? Symptom.
Frequency of micturition and defecation, sir.
Is it a frequency or difficulty? Micturition, defecation is not, the frequency is not created by a mass.
Yes.
So you will have a constipation.
Constipation symptoms. Yes.
In your clinical examination,
in a male patient, how will you differentiate whether it is the prostate or whether it is the Bloomer cell? In a male patient.
Male patient.
How will you differentiate?
So prostate will have
maturation symptoms. I mean, patient will have difficulty in the starting the.
I'm asking on the clinical examination.
Prostatic
You are
cancer may
doing
not
the DI.
have a.
Yes, sir. Prostate again is anterior.
Both will be anterior.
Prostate. Sir.
Both will be anterior. Isn't
Both will be
prostate
anterior.
will be also anterior, and Bloomer shelf will be also anterior.
Yes. Yes.
So how will you know that whether it is a prostate or whether it is a Bloomer shelf?
Yes, sir.
Which is lower, which is higher?
So prostate is higher, sir.
Prostate will be higher.
Sir. Sorry. Sir, sorry, sir.
Prostate will be lower. Bloomer
Yes,
shelf
sir.
will be higher. No?
Yes.
Okay. Parthiban, in the clinical examination, you have said there is a satellite nodule.
Yes, sir.
And there is a PD orange.
Yes, sir.
Okay. Can you explain what is that satellite nodule? What do you mean by that?
So it's a nodule away from the lump to along the lymphatic, some 2 centimeter away from the main lump, sir. It is a involvement of the skin by the dermal lymphatics, sir.
So why it produces a nodule? Then it is going to the lymph node. Any speciality of the lymphatics of the cutaneous region of the breast? Breast lymphatics are mainly segmental.
Segmental.
So it is crossing from one segment to other segment is rare.
Yes, sir.
So why do you get PDRS?
So again, the blockage of dermal lymphatics and the air follicles, the blockage of dermal lymphatics, we get PDRS.
So you have a reason why?
Sorry, sir.
No, blockage of, is it a significant when there is a block,
Yes, sir.
lymphatics are blocked? Is it a skin involvement?
Yes, sir. This is comes under the T4B skin involvement, sir. Beauty
What
orange
is coming
satellite.
under? Pure just blockage of the lymphatic, cutaneous lymphatics do not comes under T4B.
With edema, sir.
Edema and
Edema,
the permeation of that lymphatic. When there is a tumor cell is blocked, it has
Yes,
to permeate out and come to
Yes,
the
skin.
then only it will also for
Yes, sir.
involvement of the cutaneous involvement.
Yes, sir. Skin
So
involvement.
your patient has something away from that mass. You said the mass is in the retroareolar region. Now
Yes, sir.
away from that you are having a PDRS.
It is in the lower inner quadrant. There was PD orange appearance were appreciated. When the patient lifted her arm above her heads, it was more appreciated, sir. Appreciable. In the lower inner quadrant, sir.
So will you say it is not a Paget's disease? There is a lump behind.
So Paget's disease.
Cutaneous with extensive
Yes, sir.
cutaneous lesion is there.
Yes, sir. So Paget's disease mostly involves the nipples, sir. The eczema of the nipples. They hear the nipple is bad. Nipple is bad.
Nipple areola complex. It doesn't involve the nipple straight away.
Over the nipples, there's no eczema, sir.
What is Paget's disease?
So Paget's disease is a precancerous lesion with the eczema over the.
Is it a carcinoma in situ or precancerous lesion?
So it's a carcinoma. It's a precancerous. It predisposes to ductal carcinoma. Sir.
No, there's nothing to do with the ductal carcinoma.
Parthiban.
Yes, sir. Yes, sir.
Is it TIS or not? What is the stage of Paget's disease? T staging of Paget's disease.
So Paget's disease comes under invasive carcinoma. So it's a type of invasive carcinoma. Under Stewart's classification, it's a type of invasive carcinoma, sir.
No. See, the point is whether it is associated with the lump or without the lump. When there is no lump, when the Paget's disease is present, it is in situ carcinoma. When there is a lump beneath a Paget's disease, the T stage is based on the size of the lump.
Okay, sir.
Okay.
Okay, sir.
When there is no lump, it is TIS.
Okay, sir.
Yes, sir.
Cutaneous manifestation of the underlying
carcinoma. Yes, sir.
Why do you get extra mammary Paget's disease? Is it Paget's disease only in the breast or you get it outside also?
Outside also you can get, sir.
Where? Commonly. You can get in the penis where the apocrine gland. It is an adenocarcinoma.
Yes,
Equivalent
sir.
to this is a Bowen's disease and erythroplasia forehead. That's what both are squamous cell carcinoma. So here it is. So
yes, sir.
This case, because looking like a mass, looking like the cutaneous involvement, so you should also consider. Okay.
Yes, a different diagnosis.
And why you have put as a M1 disease here? Your staging you have put as a M1.
Sir, yes, sir. Sir, in the right axilla, we are able to palpate a node, sir. On the right axilla, sir. Without a mass in the right breast.
So, do you think this mass possibility it is crossing that breast and going to the opposite?
We are suspecting, sir. We did
your
one.
Node is only a 1 into 1 centimeter.
1 into 1 cross, yes, sir.
Mobile
I have
node.
to substantiate with an FNAC report. This is a clinical diagnosis, sir.
Do you, because your mass is in the inner quadrant, where do you expect the node to be?
Yes, sir.
Now,
More on the internal
axilla,
mammary lines.
So, have you checked for the internal mammary node?
On percussion, that's not resonance, sir. I would like to do a CT chest, sir.
Where do you percuss?
On the parasternal region, sir.
What is the commonest space you will get internal mammary node?
The intercostal space, the parasternal region, sir.
Yeah, there is entire ribs has a paragastric region, no? So the common
Yes, around the third and fourth intercostal space.
Below that, okay.
Yes, sir. Third and fourth intercostal spaces, sir. This mine is a clinical diagnosis, sir.
Pratibhan, how will you proceed? How will you make your?
Yes, sir. So I would like to investigate with a triple assessment, a clinical investigation being done. I'd like to proceed for the radiological investigation with a sonomammogram and a wedge biopsy from the lump.
Now, why do you want to do a sonomammogram in this patient? The purpose of doing the sonomammogram in this patient?
So with the scar tissue, mammogram, so usually for postmenopausal women, we prefer mammograms. And here being a hard lump with a scar tissue, I would like to add a sonomammogram, sir.
No, but how the sonomammogram is going to help you in the management of this patient?
Say it can give an idea about the extent of the lesion, whether it is calcified.
Clinically, all the quadrants are getting involved in this patient.
Yes, sir.
It's a small breast is there.
Yes, sir.
And you have got about 8 centimeter mass.
Yes, sir.
So, is the sonomammography is going to help you in the management of this patient?
So it can substantiate my diagnosis, to confirm my diagnosis.
It can't confirm your diagnosis.
Do you have any clinical doubt about that this is not the carcinoma?
So, clinically, it's possible. It's a probably it's carcinoma only, sir. But the definite diagnosis I can give with a radiological and histological, pathological examinations.
Yeah, only the pathological.
Pathological examinations.
Mammogram will not give you a definite diagnosis.
Yes, sir. Yes, sir. It's a contributory.
So, what is the blind spot in the mammogram? Normal routine mammogram. What is the blind spot? Retroareolar region is a blind spot. You will not be able to see because the nipple is. So your mass is also.
Yes, sir.
Mostly a retroareal region. Any specific modification you do on the mammogram? What is the advanced mammogram you do to overcome this blind spot?
Spot regression. I mean, 90-degree lateral CC craniocranial. Neocaudal view.
What is tomosynthesis? What is 3D mammogram?
3D mammogram is a 3D reconstruction of the.
So in that case, I think when you are suspecting the retroareolar region, ideally it's the 3D mammogram.
3D mammogram. Yes, sir. Yes.
You want to do for this breast or opposite breast? Mammogram for which breast?
Both breasts, sir. I want to rule out synchronous or metastasis lesions.
Synchronous or metastasis? Is that the only reason? Why do you want to do mammogram?
Sir, So to look for lesions, carcinoma and the other breast also.
So that is fine. This breast is a very large lump is there for
Yes,
this
sir.
breast, and what do you want to do?
So I want to know the extent of the tumor.
So you want
See,
to
which
assess the
is very
volumetric assessment, because we are going to start on the chemotherapy.
Yes,
We are
sir.
going to assess the response of the tumor.
Yes, sir. Yes, sir.
So
I want to-
volumetric assessment.
Volumetric assessment. Yes, sir.
So Karna sir, you can ask.
In this patient, if you say that I will do the mammography of the right side, I will be much more happy.
Yes, sir.
Rather than doing on the left side.
Yes, sir. Right side
Because you
also.
are saying that
We
you
did,
want
sir.
to see
Actually,
that if there is any
we did
lump
mammogram.
there,
Yes, sir.
the right side.
Yes, sir. We did, sir. Yes,
And then you are saying it's a wedge biopsy.
sir.
Why you are, from where you are doing the wedge biopsy? Because hardly I see any
Sir.
ulcer there. Though you are describing it as an ulcer there, but I am not sure that really there is any ulcer is there or not.
Yes. There was an ulcer. Yes, sir.
There was an ulcer?
Yes, yes.
Yeah, but yeah, clinically, from the photograph, it doesn't look like that. Yeah.
Okay. Yes, sir.
Definitely. So you have a healed ulcer.
Yes, sir. It is,
So
this is
malignant,
taken.
it's a non-malignant ulcer then.
Yes, sir.
Malignant
1 week
ulcer will
back.
not heal.
Yes, sir.
No, if you are having a healed ulcer, think
Yes, sir.
twice on your diagnosis. It's a malignant ulcer.
Yes, sir.
Pratibhan, I wanted to ask you, what is that big bulge which we see on the left side? That
So that is a normal breast. I've taken from this angle. Sorry, sir, but it's not axillary. I mean, axillary node is not seen, so only palpable, sir.
where in this whole breast is very small breast, as
Yes,
Dr.
sir.
Ajay Khanna sir told.
Yes, sir.
So that black thing, what you are seeing is what?
That was
what he's
ulcer
saying is
and
ulcer.
display.
scab. Is it a scab?
Crusting, sir. Yes, sir. She presented with this. She said for the past 2 weeks she's having this ulcer.
What does crusting indicate in general?
Healing.
Which malignancy you can get some kind of a crusting? Basically, it tells healing.
Healing, sir.
Healing is definitely not a property of the malignancy, but which malignancy you get this kind of a thing. That means slow growing. Sometimes it heals, opens, heals, opens.
Phylloids.
No.
Sir, no.
Not phylloids.
Malignancy, sir.
No.
A cutaneous malignancy.
Yes. Which cutaneous malignancy? Correct. So not melanoma. Don't.
Yes. No, sir. Sorry, sir.
Very
Melanoma
slow
is
growing.
Stars are slow.
basal
Okay,
cell carcinoma.
Yes. Okay, sir.
Because it is the only thing it has got that scabbing like thing it happens, then suddenly slow growing can many years.
Yes,
So
sir.
I'm not sure how to explain this lesion which is black pigmented in this patient, what he is showing, whether it's a very slow growing neoplasm there arising from there. You said some big lump is palpable, no?
Yes, sir.
8 centimeter something.
Yes, sir. Yes, sir.
So best is to do a core needle only when
Yes,
this
sir, we did.
lump is there.
Yes, sir. Yes, sir.
Not advisable to do in wedge biopsy at this moment. You can
Okay,
do
sir.
still a coordinator biopsy.
Okay, sir.
Any fungal infection you are suspected in this patient? No, doesn't look like, no?
Doesn't look like, sir.
Okay, fine.
Can it be a melanoma?
Possible, sir. But our biopsy.
Hello, biopsy.
Yes.
Biopsy will come.
Sorry, sir.
Okay, so you have done the true cut biopsy. In this.
Yes, sir.
Have you done the true cut biopsy?
Yes, sir.
Okay, so what is the biopsy report?
It came as a ductal carcinoma, sir.
Grade?
Moderately differentiated. And right node is a carcinomatous metastatic deposit of ductal carcinoma it has come, sir. Right
the
side.
right axilla.
Right
the right
axilla.
axillary node. Okay.
Yes, sir.
So that is a metastatic disease.
Yes, sir. So we are planning we are awaiting a hormone status. We haven't received, sir. We are yet to receive, sir.
The right breast, you are sure there is no, because it looks like.
We did a mammogram. It was normal, sir. Right breast mammogram was normal, sir.
So what next you are going to do?
Sir, Then I work out for a stage. I mean, for metastasis, did some investigations, sir.
See, Parthiban.
Yes, sir.
See, you have put M1.
Yes, sir.
So when there is one metastasis, when there is an opposite axillary node, it is M1, as you said.
Yes, sir.
Still, you want to go for another metastasis. So will it going to be M2?
No, sir. It's not. It's not going to change my diagnosis.
Then what for your?
But I want to rule out to plan my treatment.
What is your principle of treatment in this case?
So palliative therapy, sir.
Yes. Yes.
I'll discuss it within a multidisciplinary tumor board.
Yes.
Then we came to a consensus of palliative treatment.
Yes.
And if possible, a toilet mastectomy also, sir.
Why toilet mastectomy? Can the term fit correctly? What is toilet mastectomy? What is palliative mastectomy? Is there any difference?
Sir, toilet mastectomy for the ulcer part, sir. For any fungation, we do toilet mastectomy. For any fungation.
See, toilet mastectomy is also a palliative mastectomy when there is a fungation and foul-smelling discharge. In order to get rid of these things, we do a palliative mastectomy, which is called as toilet mastectomy.
Okay, sir.
Okay.
Yes, sir.
So the principle behind your treatment is palliation. What other palliation you can do in this patient?
So after getting a hormonal status, ERPR and HER2 status, I'd love to plan my chemotherapy and hormone therapies for palliation.
Which one do you prefer, hormonal therapy or chemotherapy for this patient?
For this patient, hormonal chemotherapy for its toxicities. Of course, we'll give the benefit of chemotherapies. We have to give, sir.
No, in the front line, the chemotherapy is indicated when you have a visceral crisis. You have a hepatic failure, things in acute management you need. Otherwise, the best line is a hormonal therapy. What hormonal therapy?
So if it turns out to be a ER positive, I'll go for aromatase inhibitors.
So in the postmenopausal, always prefer
aromatase inhibitors. Yes, sir. And if it is a HER2 new positive, I'll go for trastuzumab.
You want to detect the bone secondaries?
Yes, sir.
Why?
To alleviate bone pains, I can.
Why? What bone pain?
No, if at all she develops pain, I can plan my treatment.
For bone secondaries, when there's already a secondary somewhere else, is it necessary?
Sorry, sir.
Is it necessary to look for a bone secondary when there is a metastasis elsewhere? In this case, the opposite contralateral axillary node.
Yes, sir. Yes, sir.
Yeah. See, metastatic breast cancer is classified as those with bone secondary and those without.
Yes, sir.
There's a reason for this classification.
Yes, sir. If there is bone secondaries, we need to start on bisphosphonates for pain relieving.
Why do you want to start on bisphosphonates?
If there are both secondaries, sir.
Why?
It relieves the pain and pain symptoms. And
no. Bisphosphonate not for the pain relief.
Okay. It's an anti-metabolite. Prevents fractures.
The reason why you want to treat the bone secondary? What are you worried about?
Fractures, sir.
Any changes in the calcium?
Yes, sir.
So what will happen in when there is osteolytic lesion?
Osteolytic lesion, hypercalcium.
So what is the role of bisphosphonate?
So it's anti-metabolite. Sorry, sir.
What about secondaries in the spine? Are you worried about them?
Yes, sir.
What are you worried about?
Paraplegia.
Yes.
Yes, sir.
How are you going to treat them? With bisphosphonate or some other modalities there?
We give spinal braces.
Any other?
You have an isolated secondary in the spinal cord. In the spine, will you treat?
Yes, sir.
You want to give a radiotherapy, you want to give chemotherapy, or anything else? You as a surgeon, anything else will be preferred.
So radiotherapy also can be given, sir.
No, that's not the first choice.
Yes, sir. And systemic chemotherapy, sir.
Always do the surgical resection.
Okay, sir. Surgical resection. Okay, sir.
When you're giving the zoledronate and pamidronate,
Yes, sir.
what precautions you take? What you have to give along with them? Whenever you're giving a bisphosphonate, no?
Yes, sir. Yes, sir.
That, what are the drugs you will give? Will you give calcium? Will you give vitamin D? Will you do RFT every time you give it? Renal function test?
Yes, sir.
Cause renal failure, these drugs.
Yes, sir. Yes, sir.
Urea and creatinine, and you have to give vitamin D and calcium along with
vitamin D3 and calcium. Okay, sir.
So, suppose you have a secondaries in the brain.
Yes, sir.
So how you are going to manage? It is a HER2 positive also.
HER2 positive, we start on trastuzumabs.
I said specifically, it's a brain secondaries.
Brain secondaries.
What is the problem with the trastuzumab?
Sir?
What is the problem? Drugs with Herceptin or trastuzumab. It will not cross the blood-brain barrier.
Cross blood, yes, sir.
It will not cross the brain barrier. Okay. So what is the drug of choice?
Taxane, sir. Chemotherapy.
Taxane is a chemotherapy. We don't use that.
Okay.
It's a monoclonal antibody.
Monoclonal antibody. Yes, sir.
Leptopnib.
Okay, sir.
How do you assess the response of the chemotherapy?
Sir, in a metastasis disease, sir.
Any metastatic or locally advanced breast cancer, you are giving the patient chemotherapy.
So in a locally advanced breast cancer, I can use a metallic clips in the breast, sir.
No. What is RECIST criteria?
The RECIST criteria is response evaluation criteria in solid tumors, where the if it is a complete pathological response, they grade it as a partial response or a stable disease or a progressive disease. A complete pathological response is a disappearance of the initial tumors, and partial response more than 30% of the tumor in its greatest dimension. If it is reduced, it is a partial response. Stable disease, it is neither partial response or a progressing disease, it is stable disease, sir. And progressive disease, if it is the lesion is growing by more than 20%, or if there are new lesions, we take it as a progressive disease, sir.
So by giving the patient the chemotherapy, in a case of the cancer, like in this patient, if you are giving the chemotherapy,
okay, sir.
So what are the things you are going to assess, that whether the patient is responding or not?
Size of the tumor.
Yes. So
and
all the clinical
Ki-67 levels, Ki-67 levels measures the tumor progression.
You have to carry out, like in the patient who has got the locally advanced breast cancer,
okay,
that what was the lesion or investigation which showed the positive things.
Okay,
and what is happening to that?
Okay, sir.
Apart from the primary tumor which is there.
Primary tumor.
Suppose your tumor turned out to be a triple negative.
Okay, sir.
What are the other options you have?
Triple negative, they are very aggressive tumors, so they respond to taxane, sir. Taxane-based chemotherapy.
You know, what are the various luminal type of the cancers?
Immunotypes, sir. Luminal, yes, sir. Depending on the molecular types, it's classified as luminal A, where there is ER and PR positive and HER2 negative. Luminal B, it is a triple positive, sir. ER, PR, and HER2 all are positive. And next type is the HER2 new enriched type. That is the HER2 is positive, ER, PR are negative. And the other type is that basal type, where it's a triple negative basal type, sir. And of course, another miscellaneous type is also mentioned.
Parthiban, luminal A and B not based on the F2. F2 can be positive, can be negative. Going to measure ER, PR and Ka67 and Ka67.
K67.
So high ER positive, low Ka67 is luminal A. Low ER positive,
luminal
high Ka67 is luminal B. Plus or minus F2 result.
F2 news.
What do you expect the prognosis in your patient, in this patient?
Poor prognosis, sir.
What is that poor prognosis?
You should talk in an oncological term.
How much is the 5-year survival rate for the stage 4 cancer?
Hardly 10%.
Okay.
Okay.
Should we stop it here now? Dr.
Yes,
Kennedy is saying here.
I already have sent a message.
We can take another 5 minutes, sir, if you feel like.
Any role of mTOR, you know? mTOR, PDL?
Yes, sir. mTOR, everolimus mTOR inhibitors, sir. They are responsible for tumor progression, tumor division, cells division, sir. So mTOR pathway inhibitors like everolimus can be used, sir.
Especially when you have a triple negative.
Everolimus.
You are going
Yes,
to do. There is a newer. So once you have metastatic carcinoma, definitely you used to do a genetic markers specifically on that.
Yes, sir.
And PRP, PARP inhibitors.
PRP inhibitors.
And all this.
CDK4 inhibitors. CDK4 and 6.
So this is a second level. When a metastatic carcinoma, which responds to visceral crisis or responds to chemo ER positive, there's a one line of treatment.
Yes, sir.
Then you have a genetic management, you have immunotherapy. So all that you have to, especially when you have a theoretical question is asking on a metastatic carcinoma management, you have to go ahead all of that.
Yes, sir.
So do you know what is the liquid biopsy? Liquid biopsy.
Normally we do biopsy from the tissue, no?
Tissue, sir.
So what is liquid biopsy, sir?
This is the detection of the cancer cells in the circulation.
Circulations.
Okay. So you will take the blood sample and then you will detect those cancer cells. That is called a liquid biopsy.
Liquid biopsy.
You know what are the various concepts of spread of the cancer breast?
It's mostly lymphatic, sir. Except for pilloid tumor, which is sorry.
No, what is the Halstead concept? What is the Fisher concept? What is the spectrum concept?
Sorry, sir.
Okay, Halstead's concept is based on that when he started doing the radical mastectomy. He said that this is just a line by line involvement of the tumor. Means it will go from the breast cancer to the first axillary node, then to the second, then to the third, and then it will go to the circulation. Okay. So that is why he also described what the radical mastectomy. But the Fisher came, what we were discussing of the tumor doubling time.
Yes.
That even if the tumor is only 5 millimeter size, you may have a systemic spread.
Yes.
That is the Fisher concept. But both concepts were not correct. So that came as the spectrum concept. Spectrum concept is where the tumor has got both tendencies. It can present just like the Halstead and also as the Fisher also. So the local spread also is there, plus always the systemic spread. And that is why you are taking these combination of the treatments for the breast cancer.
Yes.
We are not only depending on the loco-regional disease, but we are combining the loco-regional for the systemic treatment based on that spectrum concept.
Yes.
Okay.
Yes, sir.
Okay, Pratibhan, you have done actually good presentation and good answering also. You have prepared well. So I will ask you one question.
Thank you.
So starting from the Halstead's radical mastectomy, then modifications came. I hope you know modified radical mastectomy. They may ask you patty mastectomy, Beckham cross, etc. Then in between something came. conservative to conserve the breast.
Breast conservative surgery.
Yeah, what is that surgery? It became popular
Yes, sir.
for few years. In fact, what is quart?
What is quadrantectomy with the radiotherapy, adjuvant radio?
There's one A there. What is A?
Axillary
Axillary
dissection,
block dissection and RT.
with the radiotherapy.
You know who did that first and became popular? Veronese, and from Milan. You know why Milan is the fashion capital of the world? You know, so a lot of the ladies registered there. They were the first one who said we'll try to conserve the breast. So the trial went, but what is the problem ultimately? Why we are not doing it now?
So what chance of recurrence, sir?
Why? No, not the quadrant. That whole quadrant removal is not required. Understand me better.
Yes, sir.
Only a centimeter margin or what depends on this. Earlier they take a one quadrant for a.
Yes.
So from the radical, modified radical, quart therapy, now breast conservation in the form of wide excision. So this is what they expect you to tell, how the progress of the mastectomy conservation has come all the way, changes. Depends upon the various theories.
Actually, no, sir. Can I interrupt?
Yeah, please.
Sir, in 1990, New England Journal of Medicine, both Veronese and lumpectomy came one after the other. The articles are consecutive. Their research. So Veronese went out of vogue, but the second one, the one that came where they did only the lumpectomy, that became the vogue.
Standard.
Both came, if you read that articles, 1990, one after the other. New England Journal of Medicine. And Fisher's hypothesis is flawed because he did cheating in that. So there is academic fraud in that, where he that was not actually what it was supposed to be. So that's why the credibility went off of Fisher's.
Parthiban, this quadrectomy means how will you decide the quadrant when you have a nipple is retracted, large mass is there?
How will you define quadrant, sir?
Yeah.
In this case, quadrant, sorry.
No, is it at the time of your presentation of a mass, you are going to decide the quadrant, or it is the normal breast?
Normal breast.
So there again you have a problem. To decide on even the quadrant, it will be very difficult in a case when you are coming in a late stage.
Okay.
There were a lot of issues with that, but typically what they started, because the quadrant, outer quadrant was the most common quadrant.
Most common.
So that is the reason why they thought, along with that, same you can knock out the axilla. This is how it started with this. Some people said separate incision. So this is how it is.
Okay.
Anyway, it of course always followed with the radiotherapy, etc., etc. Anyway, these are some of the questions.
Senior Veronese, he carried out the quad, but the Paulo Veronese, his son is there. In fact, I had a chance to work in Milan in Veronese, and now they are all going for the breast conservation only.
Yes.
Not the quadrectomy.
Correct.
And it has been definitely proved that you must add the radiation after that. If you do not add the radiation to that, then please do not do the BCSJ. That is a important or mandatory thing which is there, has to be carried on the BCSJ.
So now advance of accelerated partial breast radiation has come.
Yes.
So the full radiation, instead of going there, APVA you can go on. Can I wait, sir? It can close.
Sir,
only person still with the mask is can I wait, sir? We are able.
No, sir. Here it is again becoming a nuisance, sir. We have now 6 patients in the hospital.
Okay.
So I don't know. They are not sick, but this suddenly again they started testing. I think if you are going to increase the testing, cases are going to increase. That is how our microbiologist is telling. But then today, police stopping everywhere because government has announced 500 rupees fine for not wearing mask. So as of now, one on ventilator, sir. retrospectively diagnosed after they went into ventilatory failure, then respiratory failure, they diagnosed to have corona. So hospital has been inspected by the health authorities and all of us. They've in fact taken 30 of our nurses samples also, sir.
Okay.
So I think it's starting now. Delhi is also reported many cases.
Total number of cases now come to 2,500 from 1,000. It has increased now drastically.
The IIT Chennai team in one hostel, there were about 12 students turning positive, sir. In the same floor, in one of the IIT Chennai hostels, they've turned positive.
We hope it is minor. That's what we can hope. Vaccinated, we're all vaccinated. So booster also taken.
Yes, sir. Yes, sir.
We feel probably milder variety.
Yes, sir. Yes, sir.
Thank you.
Thank you, sir. Parthiban, do you
Yes,
have
sir.
any doubts to get clarified from the senior faculty here? I think you have done enough hard work. Thanks to
Thank you.
Rajuvelu, sir. Sir
Thank
is
you,
there,
sir.
Rajuvelu, sir?
Sir, I want to thank my professor, sir, for giving me this opportunity. Professor Rajavelu, sir, and my unit chief, Professor Manikandan, sir.
Rajavelu has not joined.
And
No,
I want to
sir,
thank
he was
all the
there
senior
for some
faculty,
time, sir.
senior professors who have helped me to
Congratulations to
gain the
Rajavelu,
knowledge.
sir.
Credits to
No,
I
Rajuvelu.
thank
good
all,
thing,
all
good thing,
my, all the,
Parthiban, you are very composed. We
yes,
are
sir.
very not very going not in a speed. Just
Okay.
very